You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 11th, 2022. This week is part one of at least two, probably three podcasts on the 2022 AHA, American Heart Association meeting. First, 4 brief comments on the AHA meeting in Chicago. First is the pandemic has taught us many lessons, but one is surely the inferiority of virtual learning. I've given a bunch of in-person talks in the last year, and they are vastly better than virtual. On Zoom, you talk into a screen, you can't see the audience, you have no idea if you are connecting. I hope all the societies eliminate virtual options, period. Good riddance. Okay, another huge positive with AHA was that it really looked different than a typical cardiology meeting. On the stage and in the halls, there were young people, women, and underrepresented groups. This is a very good thing. I'm no expert in diversity, but it seems to me that the way to diversify is via diverse mentors. All right, 2 negatives about AHA and really most American cardiology meetings. First is, I don't get the impression that practicing doctors come to these things anymore. I remember the days of old when the halls would be streaming with regular doctors. The sessions would be filled up. Now it seems that the only people who come are the presenters, the faculty, and industry. No one in my group has come to a meeting purely for education in years, and perhaps it's the time away, the expense of the hotel room, and travel, and the ease of CME from other sources. If professional societies want to continue to have these meetings, they're going to have to attract regular practicing doctors. Give them something they can't get from a PowerPoint CME lecture or a booklet. Which brings me to my final critique. Cardiology meetings have become way too agreeable. Take the late breakers, for instance. It's like an award ceremony or cheerleading session. I get that research is hard, and it's wonderful to see a study through to finish. But these are practice-moving studies. They deserve serious critical appraisal. I mean, the authors themselves rarely focus on their limitations. The discussant spends 1 of their 3 minutes congratulating the authors, and then there's no time for a panel discussion. I mean, maybe there's a deep dive later in the afternoon, but these are also just more time for celebration. You can have deep respect for the evidence generators and still submit these papers to critical appraisal. I mean, I see more critical appraisal in a journal editorial, and that's sad because journal editorials are rarely critical. I want a world where a paper would be presented. Then the audience could expect it to be vigorously appraised. Then the authors and panel could engage in debate. And this might motivate more practicing doctors to actually show up. Now, you might push back and say, Mandrola, if they did that, there wouldn't be enough time to do all the late breakers. And to this argument, I would say, please, you could easily debride 1/3 of the late breakers and lose nothing. Science should never be about cheerleading. Debate ought to be center stage, as debate is science. Okay, let's do some trials. First, ISCHEMIA-Extended. At AHA, co-primary of the ischemia trial, Dr. Judith Hochman presented results of the extended follow-up of the ischemia trial. The results were about as clear as any result at AHA. But before I tell you, let's briefly review ischemia. Published in New England Journal in 2020, ischemia randomized more than 5,000 patients who had very positive stress tests, proven coronary disease without left main disease, to an early invasive strategy or delayed invasive strategy with medical therapy first. At 3 years, there was no significant difference in the primary endpoint of CV death, MI, unstable angina, heart failure, or cardiac arrest. There were also near identical rates of death in both arms. Now, crucially, the most important finding from the original ischemia trial was tucked away in the supplement. Figures S6A and B show that these similar results were had with 60 to 70% fewer angiographies and PCI. At AHA, we learned about the extended follow-up. This paper included roughly 4,800 of the original 5,200 patients in the trial. The median follow-up was now 5.7 years. After the original trial, there were 289 patients, or 5.6%, who had died. The extended follow-up included another 268 additional deaths, so more events means more precision. All-cause death was nearly identical, hazard ratio 1.00, with confidence intervals that were nearly symmetric around that 1.00, 0.85 to 1.18. Now, the authors told us that CV deaths were significantly lower with the invasive strategy, but non-CV deaths were higher. They also told us that there were no differences in subgroups, which I know sounds a bit like jargon, but I should remind you that even the most severe disease, the early invasive strategy with its higher rates of revascularization did not lead to better survival. Now, much was made at AHA and in a circulation paper of the diverging causes of death. In the invasive arm, CV death lower, but non-CV death higher. My friends, don't be fooled by this. The authors tell us that, quote, cause of death in the extended follow-up is not being centrally adjudicated. It's a fool's errand to try to sort out causes of death, especially in extended follow-up without central adjudication. Also, death is a totally appropriate endpoint in such a study. You know why? Because the reason doctors still send patients with positive stress tests to catheterization is because they are afraid a blockage will kill their patient. Ischemia and its extension study shows so clearly that even the patients with most severe coronary artery disease can be treated medically, have deferred angiography done only for clinical worsening. And again, I've said this a blue million times, the only remaining mystery of stable coronary disease is why mountains of evidence cannot convince doctors. Because I guarantee you that in most institutions, a patient with a highly positive stress test will soon have a catheter in their wrist. All right, next trial, STRONG-HF. The strongest trial at AHA had the most apt name, but before I tell you anything about this outcomes trial in the heart failure space, which was published in The Lancet, I want to tell you the results first. The active arm of the trial led to a 34% relative and 8.1% absolute risk reduction in the composite of death or heart failure readmission. CV death, 26% lower. All-cause death, 16% lower. Heart failure readmission, 44% lower. If this were a drug or a device, the booth would take up 1/5 of the expo, and it would be in the New York Times and Wall Street Journal, and there'd be banners going up the stairs at the Congress Hall. But it wasn't a drug. It was a strategy of care after discharge from the hospital for an acute heart failure episode. STRONG-HF enrolled about 1,600 patients with acute heart failure who were not treated with optimal medications from 87 hospitals in 14 countries. Nearly 90% of patients were recruited from Africa and Russia. Patients were randomly assigned to a high-intensity treatment arm or usual care. The high-intensity arm was intense. Patients first were given half the optimal doses of heart failure meds while still hospitalized. These included RAS blockers, beta blockers, and MRAs. At week 1 after discharge, patients were checked for tolerance of these meds. At week 2, meds were up-titrated to full dose. The week 3 visit was used to check tolerance of full-dose meds, and then patients were checked again after 6 weeks. Notably, cardiologists performed these, quote, safety checks using only a history exam and measurement of basic labs. Quality of life measures were also better in the active arm, as were signs of congestion, and boy, did medical management differ. Far more patients in the high-intensity arm were on optimal doses of the 3 classes of heart failure meds. SGLT2 inhibitors were not yet used during the trial. Of course, at AHA, more medicines was given the nod for all the credit, and no doubt that helped, but also 4 visits in 6 weeks surely entailed lots of education and caring. Now, one of the criticisms I heard at AHA was that because most patients were enrolled from Russia and Africa, the control arm probably had suboptimal care. So good care is always going to beat suboptimal care. But I want to push back on that because I could cite oodles of papers showing how poor GDMT uptake is in the U.S. We don't do much better outside of clinical trials. Another criticism was that these were young ambulatory patients with few comorbidities, and most of the patients admitted for heart failure are older and have multiple morbidities, which is true, but who's to say that a strong HF-like protocol might not work for older patients with multimorbidity as well? I mean, not so much to maximize tablets, but to ensure treatment of all comorbid conditions, including maybe the provision of palliative care. Strong HF is provocative. It showed that if you get people 4 visits in 6 weeks after a heart failure admission, in which patients are maximized on meds, they do better, lots better. Strong HF-like protocol could not be done in my system right now. There's nowhere near enough people power. I suspect we are representative probably can't be done in your system either. This is what I wrote in my column that I hope you read up on the heart.org Medscape Cardiology. Quote, if we use evidence to guide practice, health systems have their work cut out for them if they want to implement a strong HF-like protocol. It will require a massive investment in people power and will not come at a low cost. Health leaders love to talk about better outcomes. Now it's time to bolster talk with action. I look forward to watching how strong HF influences healthcare systems. Okay. Next topic, experts versus practicing docs when it comes to the initial treatment of hypertension. The DCP trial, Diuretic Comparison Project, compared cardiovascular outcomes with HCTZ versus chlorthalidone in patients in the VA system who had hypertension. Now, there are 2 hooks to this trial that make it fun. First is that the ACC-AHA guidelines writers favor chlorthalidone over HCTZ, but every practicing doctor I know uses HCTZ, and in observational studies comparing the 2 drugs usually have 9 times more patients taking HCTZ than chlorthalidone. What do practicing doctors know that experts don't? Why is there a discrepancy between recommendations and actual practice? And of course, I love experts versus working stiff doctors face-offs. Now, the second hook of this trial was the way the authors accomplished these comparisons. Namely, they embedded the trial right into the EHR and the normal practice patterns of the clinicians. There was no special research visits. So veterans who were taking HCTZ were called after the authors got permission from the primary care clinicians, and these patients were asked to participate in a head-to-head comparison of the 2 drugs. Half the patients were randomized to continue HCTZ, and the other half were switched to chlorthalidone. These were about 6,000 patients in each arm. After 5 years, there were no differences in the primary outcome of stroke, heart attack, non-cancer death, heart failure, or the need for coronary procedures. The hazard ratio was 1.04 with 95% confidence intervals of 0.94 to 1.16. However, there were more adverse events in the chlorthalidone group, primarily low potassium levels, though this was not enough to affect the primary outcome. Gosh, my friends, this is such a cool study. Think about it. It had to be done, right? If the experts were right about their first-line choice, and there was even a tiny signal of benefit for chlorthalidone, this would have been an important thing to know because there's so many people with hypertension taking HCTZ. The other thing I love is that the experts were wrong and working stiff doctors were right. That's provocative, but I wouldn't take it too far. I would not posit that it was the cumulative wisdom of those that see patients every day. I wouldn't say that because history has proven us working stiffs doctors to be wrong very often, right? PVCs after MI, hormone replacement therapy in postmenopausal women, Swan-Ganz catheters, cardiac cooling, and survivors of cardiac arrest, and I could go on. The way to know what works in medicine is not to rely on cumulative wisdom. Instead, is to do exactly what Arif Ashani and colleagues did in DCP. You make the choice to use 2 therapies random. You do a randomized trial. Now, TWIC podcast wouldn't be true to itself if we didn't mention some of the limitations of DCP. Academic cardiologist Jim Stein from the University of Wisconsin sent me some of his concerns. First, this was an open-label trial, so people were treated differently, and at a minimum, some people knew they were switched versus not switched, and people change behaviors and are treated differently when they know things. What things we don't know, but we know those things lead to differential care. Also, blood pressures were the same in both arms throughout the study. Why wouldn't there be lower blood pressures on chlorthalidone? Is that a null bias? Outcomes were from the EHR, which is not sensitive for endpoints. And the study pretty much was optimized to show low potassium on chlorthalidone. The electronic health record is good for that. And I would say to all these criticisms that they're good criticisms. I would add that we haven't seen the full paper yet. Here's the thing, though. DCP was a pragmatic trial. It's embedded in the system. It's much lower cost and burden than a standard trial. And pragmatic trials are always going to be a bit noisier with, as Dr. Stein says, less precision. And no trial is perfect. But DCP had a hazard ratio of 1.04 in a study of more than 12,000 patients. Seeing the paper would help sort out the total events, but gosh, on the surface, it seems unlikely that we are missing a truly positive result from chlorthalidone, in other words, a false negative or type 2 error. I think the biggest contribution of DCP is not only that HCT looks like the better thiazide type diuretic, but that they have shown us a framework for gaining knowledge in the practice of medicine. And imagine a future where instead of guessing which drug or procedure is best, doctors have the option to randomize patients into trials that are embedded into normal practice patterns. That would be huge. Okay, next trial, Transform-HF. Speaking of pragmatic trials, AHA featured another pragmatic trial of torsemide versus furosemide in patients discharged after a hospital admission. Dr. Robert Mentz presented results in this first late breaker of AHA. Regardless of ejection fraction, patients were randomized at 60 U.S. sites to either of the two loop diuretics, and clinicians took care of the dosing, and the primary outcome was all-cause death as assessed by a National Death Index. This was another pragmatic trial where there were no in-person visits. Transform-HF was event-driven. It was powered to find a 20% mortality reduction with torsemide, which of course is a drug that has theoretic benefits such as better absorption and possible beneficial pleiotropic effects. But I want you to think about that power calculation. I'll come back to it. 20% mortality reduction. So the trial enrolled about 1,400 patients per group. About 1/5 had an ejection fraction greater than 50%. So most of these were HFrEF patients. There was no difference in mortality. Hazard ratio 1.02, confidence intervals 0.89 to 1.18. Now, since the lower bound was 0.89 or an 11% reduction, these results pretty much exclude that 20% reduction in death. There was also no significant difference in total hospitalizations, and I want to laud the authors. Good on the authors for looking at total hospitalizations and not heart failure hospitalizations, which is usually just a small percentage. The problem with this trial, again, is the noise inherent in a pragmatic trial. There were unknown loop diuretic statuses was reported in almost 700 patients. There were crossovers on both sides. Now, I also wonder why the authors thought torsemide would reduce mortality by 20% over furosemide. I mean, we haven't seen a reduction in heart failure mortality in a trial since the Rouse trial in 1999. Now, overestimating benefit in power calculations will always allow for enrolling fewer patients, but if you enroll too few patients, you end up not answering the clinical question. Again, these criticisms should not diminish the spirit of doing pragmatic trials. I think we need more pragmatic trials, noisy as they are. All right, next topic, triglyceride lowering, the prominent trial. We have long known that high triglyceride levels associate with increased risk of cardiovascular events. The problem is that most trials have failed to show that triglyceride lowering reduces cardiac events. At AHA, we heard results of the prominent trial. an RCT of a novel triglyceride-lowering drug called pemafibrate, which rhymes with fenofibrate. New England Journal of Medicine published a CV outcomes trial of more than 10,000 patients, and right there, 10,000 patients means the trialists expect a small benefit because you don't need 10,000 patients for a therapy that has big effects. Patients in prominent had to have type 2 diabetes, mild to moderately high triglyceride levels, and low HDL levels of less than 40. Patients were already on lipid-lowering therapy, mostly statins. The mean triglyceride level of enrolled patients was about 273. A note on pemafibrate: it is a fairly novel drug that has been shown to reduce triglyceride levels. Now the results. Pemafibrate shredded triglyceride levels by more than 25%, but get this, it had absolutely no effect on the primary outcome of MI, stroke, revascularization, or CV death. This can be a fairly short discussion because given the previous trials that failed to find any signal that lowering triglyceride reduces outcomes, and now this huge trial of a drug that reduced triglycerides but does not improve outcomes, perhaps it's time to conclude that triglyceride levels are a marker of risk but not a causal factor in cardiovascular events. And if we make that conclusion, this would mean A, we can reduce polypharmacy by stopping drugs that change only a lab value but provide no cardiovascular benefit to patients. B, we could save research dollars and time by studying other theories, perhaps ways to get people to eat better and exercise more. And C, we could use triglyceride as a classic teaching case of moving surrogate markers that don't necessarily translate to benefits. So that's it for this week in cardiology. I got 5 trials in. Next week, I can probably do 5 or 6 again. So stay tuned for part 2 of the AHA recap next week. There are also some really good trials to discuss. And as always, my friends, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give it a rating. Write us a 1 or 2 sentence review. These sorts of things help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.